Welcome to the final lecture of the skeletal module. In lecture 4, we built the anatomy and physiology of the bone. In lecture 5, we covered fractures, arthritis, osteoporosis, the imaging, and the medications. Now we're going to bring it into the exam room. Your role with the skeletal system is unusually physical. You assist orthopedic exams. You position patients safely, comfortably, and in a way that lets the provider actually see what they need to see. You apply and remove basic braces and supports, but only per protocol. And you protect two people at once, the patient from falls and injury, and yourself from the lifting injury that end careers in this field. That last point deserves emphasis right at the start. Healthcare workers suffer more musculoskeletal injuries from lifting than workers in construction or manufacturing. The system you're studying today is the same system you're putting at risk every time you move a patient carelessly. Learn this material for your patients and learn it for your own back. Five outcomes, all hands on. First, prepare for and assist with an orthopedic exam, including helping with range of motion assessment. Second, position patients correctly and safely for musculoskeletal examination. The right position makes the exam possible. Third, apply safe patient handling and proper body mechanics, which protects the patient from falls and protects you from injury. Fourth, apply and remove basic braces and supports per your facility's protocol and perform the neurovascular checks that catch a problem before it becomes permanent. And fifth, provide provider-approved education on cast care, fall prevention, and bone health, and recognize the red flags that need the provider notified immediately. Here are the medical terms that you need to know to understand this lesson fully. Take a moment to look them over. We'll use each of them as they come up in the slides ahead, so don't worry about memorizing the definitions right now. Just get familiar with the words. Pause the video to take your notes. Here's the whole job on one slide. 6 responsibilities we'll take one at a time. You assist the exam, preparing the room, gowning and draping the patient, and supporting the provider through the assessment. You position patients safely and comfortably and in a way that gives the provider access to the joint or limb they need to see. You handle patients safely using body mechanics and mechanical aids. You apply and remove braces and supports per protocol, and you check circulation afterward. You educate patients on cast care, fall prevention, and bone health. And you work within your scope, documenting, reporting, and escalating, never diagnosing. Look at the line at the top because it names something distinctive about this module. In skin care, you protected the patient. Here, you protect the patient and yourself. A careless transfer can injure both of you at once. Everything we cover today has that double purpose. First responsibility, assisting the orthopedic exam. Much of the value you add here happens before the provider walks in. Prepare the room and equipment. You may need a goniometer, the protractor-like tool used to measure joint angles, a tape measure for limb circumference, which detects swelling or muscle wasting, and a gait belt if the patient will be walking or transferring. Gown and drape thoughtfully. The joint has to be exposed for the provider to examine it, and the patient has to keep their dignity. Both things are true, and you manage both. Collect the history and be specific. How did the injury happen? The mechanism. Where's the pain? Is there swelling? Has it been treated before? A clear mechanism of injury often tells the provider more than the x-ray does. Assist with range of motion and strength testing, and always compare the injured side to the uninjured side. The patient's own normal is the reference point. The card explains ROM or range of motion distinction you'll use daily. In active range of motion, the patient moves the joint themselves. In passive range of motion, you or the provider move it for them. And the rule in red matters. Never force a joint past resistance and stop if the patient reports pain. Forcing a joint can cause real injury. Then document objectively degrees of motion, what you observed, and report abnormalities. Second responsibility, and this should be review, is patient positioning. A good position does three things at once. It gives the provider access, keeps the patient safe, and keeps them comfortable during the exam. Four positions you need to know. Supine is flat on the back, face up, which is your default for a general exam and anything on the front of the body. Prone is flat on the abdomen, face down, which is used for the back, the spine, and the posterior legs. Semi-Fowler's position is sitting up with the head of the table raised roughly 45 to 60 degrees. It's essential for any patient who is short of breath because lying flat makes breathing harder. And lateral or SIMS is lying on one side, useful for hip exams, some injections, and simple comfort. The principles on the right apply to every one of them. Explain the position before you move anyone. Being moved without warning is frightening and can cause a reflexive grab or fall. Support the joints and keep the body in alignment. Pad bony prominences with pillows and think back to lecture 2 of the skin module. Prolonged pressure over a bony prominence is exactly how pressure injuries begin. Drape for privacy and warmth. And the last one, which is the safety rule of this entire lecture, never leave an unsteady patient unattended on an exam table. Tables are narrow and high. A fall from one can fracture the very hip we spent the last lecture worrying about. Third responsibility, and the one that protects your own career, body mechanics and safe patient handling. Look at the line at the top. It isn't rhetoric. Healthcare workers experience more musculoskeletal injuries from lifting than workers in manufacturing or construction. Back injuries end careers in this profession every year. The 4 cards give you the essentials. Use your legs, bend at the knees and hips, not at the waist, and keep your back straight. Your legs are the strongest muscles you have, and your lumbar spine is not designed to be a crane. Keep loads close to your body because the farther a weight is from your spine, the more force it exerts on it. And never twist while lifting. Turn your whole body by moving your feet. Get help. Use a gait belt when assisting a patient who is standing or walking. Use a transfer board. Bring in a second person. There is no prize for lifting a patient alone. And the 4th card contains an important evidence-based correction. For many years, we taught that good body mechanics alone would prevent lifting injuries. The evidence doesn't support that. Mechanical lifts and assistive equipment prevent injury far more effectively than technique by itself. So use the equipment your facility provides. It's there because technique is not enough. Fourth responsibility, braces and supports. Your course scope says applying and removing basic bracing or supports per protocol, and I want to stress those last 3 words, per protocol. You do this when your facility has trained you, checked your competence, and the provider has ordered it. Casting and splinting a fresh fracture is a provider skill. Applying a prefabricated sling or a knee immobilizer per protocol may be yours. Know your line. Fit matters enormously. Brace has to be snug enough to support the joint and loose enough to let blood flow. Too tight is not a minor error. Check the skin underneath for redness, breakdown, or pressure points, especially in older adults with thin skin. Now the pink card, which is the most clinically important thing on this slide, the neurovascular check. Before and after you apply anything, assess 5 things distal to the device. Color and warmth. Is the hand or foot pink and warm or pale, dusky, and cold? Pulse below the device. Sensation. Any numbness or tingling? Movement. Can they wiggle their fingers or toes? And pain out of proportion to the injury. That last one, together with numbness and a cold, pale limb, can signal compartment syndrome, a true emergency where swelling inside a limb chokes off its own blood supply. Tissue dies within hours. If you find any of these, you do not wait. You do not loosen it yourself and move on. You go and tell the provider immediately. Fifth responsibility, patient education. As always, 2 conditions: content approved by your provider and no independent clinical judgment. You reinforce the plan, you don't create one. Cast and splint care comes first. Keep it dry and clean because a wet cast softens and macerates the skin beneath. And the rule patients break constantly: never insert an object down the cast to scratch an itch. A coat hanger or pencil can tear the skin, and an unseen wound inside a cast can become a serious infection. Teach them what to report. A cast that suddenly feels too tight, or new numbness, tingling, or a change in the color of the fingers or toes. Those are the same neurovascular findings from the last slide, and now the patient is the one monitoring it at home. Bone health. Adequate calcium and vitamin D and weight-bearing exercise, because remember from lecture 4, osteocytes sense mechanical load and tell the bone to strengthen. Motion maintains the skeleton. And the bisphosphonate instruction from the last lecture, which you will repeat constantly: empty stomach, full glass of plain water, stay upright for 30 minutes. The card on the right is fall prevention, and for an older adult with osteoporosis, this is the single most protective thing you can teach. Remove loose rugs and clutter, light the hallways and stairs, install grab bars, wear non-slip shoes, and have the provider review any medication that causes dizziness. Preventing the fall prevents the hip fracture. The last professional topic is your scope of practice. Medical assistants are unlicensed personnel. Your authority comes from your supervising provider's license, so you perform only tasks that have been delegated to you and that you're trained and competent to do. On the left, within your scope, everything we covered today: preparing rooms and assisting orthopedic exams, positioning, draping, and transferring patients safely, applying and removing basic supports per protocol, performing and documenting neurovascular checks, providing provider-approved education. On the right, things out of your scope of practice and not your role. You do not diagnose a fracture or read an X-ray. You may observe swelling and deformity and document it, but the diagnosis belongs to the provider. You do not reduce or set a fracture, and you do not apply a fresh cast to an acute fracture. You do not prescribe or adjust medications. You do not perform radiographic imaging unless you hold the license and training your state requires, and that varies significantly by state, so know your rules. And you never make independent clinical judgments. The green bar holds this lecture's emergencies. Escalate immediately for pain out of proportion to the injury, numbness, a cold or pale limb, an absent pulse, an open fracture where bone has broken the skin, or any patient fall. The first 4 are the compartment syndrome picture, and time is tissue. Escalating is not failing. It is exactly the moment your role saves a limb. Let's bring it together with 6 takeaways. 1, you prepare, position, support, protect, educate, and escalate, always under the provider's direction. 2, When assisting orthopedic exams, gather the mechanism of injury, help with range of motion testing, and always compare the injured side to the uninjured side. 3. Know your positions: supine, prone, Fowlers and semi-Fowlers, and lateral and Sims. And never leave an unsteady patient unattended on an exam table. 4. Body mechanics. Lift with your legs, keep the load close, don't twist. And remember that mechanical aids protect you better than technique alone. 5. Apply braces and supports only per protocol, and always perform a neurovascular check: color, pulse, sensation, movement, and pain. And 6, escalate immediately for pain out of proportion, numbness, cold or pale limb, an open fracture, or any fall. That completes the skeletal module. Anatomy and physiology, then disease and treatment, then your role. Next, we take up the muscular system, the partner that pulls on every lever we've just studied. Check out these lectures for more information on today's topic.